Can manipulation be specific, and does it matter? There are two considerations when discussing specificity and manipulation. The first is, can a practitioner select a segment that is in need of manipulation and only move that segment? The second is, does being specific make any difference in the patient's clinical outcome? A recent study we will review today focuses on the latter clinical outcome question. But first, a reminder of what we know about the first question regarding adjusting only the segment you intend to adjust. It has been shown in previous studies that SMT has a wider effect beyond the intended target segment, both locally and further away from the application site. Studies in which accelerometers or microphones have been used to record the location of the crack sound associated with SMT have found that it does not always arise from the SMT application site. For example, in the lumbar spine, SMT was accurate only about half the time. Most adjustments were associated with multiple cavitations. Upper cervical adjusting causes ipsilateral cavitations as often as contralateral, and most adjusting in the lumbar and cervical spine produce multiple cavitations. Now to our review study. The title is The Importance of Selecting the Correct Site to Apply Spinal Manipulation When Treating Spinal Pain, Myth or Reality? A Systematic Review. This systematic review investigated whether clinical effects are superior when the treatment is directed at a clinically relevant joint compared to SMT applied elsewhere, which the researchers call a non-candidate site. A review of 10 studies demonstrated a range of study populations from 39 to 186. There were 6 cervical spine studies, 4 lumbar spine studies, and 5 studies that included chronic pain patients. 2 studied acute pain patients, and 3 did not specify. The number of SMT sessions ranged from only 1 to 10, and most often the outcomes were assessed immediately thereafter in 6 studies. All but 1 study included patient-reported outcomes. 7 studies reported between-group differences for objective outcomes. 4 studies did not report between-group estimates. The researchers for this systematic review calculated effect sizes from the reported within-group difference. So some definitions. Candidate site versus non-candidate site. The candidate site is the SMT site determined to be clinically relevant for outcomes as either selected by the treating clinician or if the clinician had to follow a procedure defined in a study protocol, regardless of the method described. The non-candidate site was SMT applied elsewhere in the spine, but with no clinical indication. The researchers compared 3 types of non-candidate sites. SMT was compared to SMT to the opposite side of the candidate site, at the same spinal level, but on the contralateral side. SMT elsewhere in the same spinal region, for example, cervical, thoracic, or lumbar, and SMT to a distant spinal region. They included only randomized controlled study designs on humans with spinal pain in any region and of any duration, comparing SMT applied to any candidate site compared to SMT applied to any non-candidate site, where the between-group effect sizes were reported or estimable. It's important to note, instrument adjustments and mobilization treatments were excluded from this study. Using the Cochrane measure of risk of bias assessment, they found that there was a high risk of bias for 1 study, moderate for 4 studies, and low for 5 studies. This systematic review included 10 RCTs, of which 9 were considered to have credible results. None of these 9 studies detected any statistically significant differences in the 31 outcome measurements for the 2 treatment approaches. In other words, SMT given at a clinician-determined correct vertebral level did not have better outcomes than treatment given more haphazardly. These outcome measurements included pain, disability, and other objective outcomes. The only study to indicate a clinical benefit was eliminated. Well, why? The only study to confirm the importance of treating the clinically relevant segment reported a small reduction in neck pain. Although the magnitude of this effect is below the threshold for a minimally clinically important difference in this population, this finding was statistically significant. However, that study was the only one assessed to having high risk of bias, which questions the validity of this result. Adding to these results, it's important to know that previous studies have demonstrated that it is not possible to identify patients who were manipulated versus patients who had not been manipulated, and further, motion palpation cannot reliably distinguish between individuals from the general population with or without low back pain. And a recent study concluded that the application site is not important for clinical outcomes despite attempting to target clinically relevant sites, either in relation to stiffness or pain sensitivity. So, of course, this begs the obvious question. Then why does manipulation work? Well, there are many hypotheses, none really validated at this point. These include, but are not exclusive to, the following examples. Perhaps functional changes in a biomechanical chain and spinal regional interdependence are affected indirectly, leading to pain relief. An example of this is how thoracic SMT seems to reduce cervical pain in clinical adult populations. Examples of other potential biomechanical effects are increased disc diffusion and decreased posterior-anterior stiffness. Other systemic effects could include changes in the functioning descending anti-nociceptive system, a widespread effect on muscle spindle response, and central mechanisms of pain modulation. So in summary, the elephant in the room is there an accurate method to determine where to adjust someone to maximize benefit? And the answer is simply no. Regardless of whether you use a go scope, a manual muscle test, a leg check, static or motion palpation or radiographs, there is no reliable or valid approach that has been determined through scientific comparison studies. So the studies to date, and this study, indicate that an attempt to apply an adjustment to a specific location is not entirely going to have a local effect, and that it does not appear to matter with regard to results. Note the conclusion is not that manipulation is ineffective. So why attempt to be specific? Well, one reason is safety. Long lever adjusting will often move more segments, but by increasing the lever, more tissues are stretched and may result in injury to those structures. The caution then is still needed to assure that unwanted collateral injury does not occur. Clearly, more high-quality studies with low levels of bias still need to be performed prior to drawing final conclusions that influence practice.